Okay, this video is how does radiology grow itself? And I can tell you that radiology is like the perfect business. If you have a business, you want it to keep on increasing its volume. And in radiology, that happens automatically. It doesn't, a person doesn't have to do anything to make it happen. It just happens automatically. I'll show you how that works. Well, first of all, you have when I was a resident, we were walking through this wealthy private practice hospital, and the boss of the radiology department said to the young junior residents, he pointed to the CT scanner and he says, "What is that?" So I said, "It's a CAT scan machine." He goes, "That is a machine to print money." And, there's a joke in radiology. What's the definition of a healthy person? And the answer is somebody who hasn't had a body CT yet. So a body CT means a CT scan of the chest, the abdomen, and the pelvis. And the reason is, here's the joke. What's the most common thing you find on a CT CAP, chest, abdomen, pelvis? You find an incidentaloma. So an incidentaloma is an incidental finding that could be a tumor. The majority of people, I don't know, about 70%, they have some micro nodule in their lung from some time when they had some infection. It could be when they were a kid. Nobody knows. One CAT scan is only a snapshot in time. You have to see 2 years at least with a solid nodule of no growth in order to say that it's clinically insignificant. It's definitely benign. With a ground glass nodule, you might need to follow that for 5 years. That's a lot of follow-up CAT scans. So a person could have their life put on hold for years with these follow-ups. And it's not just incidentalomas of the micro lung nodules. It's also, possible atypical cysts, possible, liver cancer, kidney cancer, etc. And I'm going to talk a little bit more about why that happens. There's been a trend to decrease the radiation dose on CAT scans, and that came out of a CT scan done in California many years ago. I don't know, about 10 years ago or 12 years ago, something like that, where a person was being scanned for a possible stroke with a CT perfusion technique, and they scanned the brain too many times and gave too high of a radiation dose. The patient had some hair loss, and a big fuss was made about that, so they started tracking radiation doses on CAT scans and making all kinds of efforts to lower those dosages. Well, the relevance is that when you lower the radiation dose of a CAT scan, you decrease the quality of the image. You introduce more noise. And if you introduce more noise on a CT scan of the abdomen, you then have all these locations where you often see normal benign cysts. But now they've got noise in them, and because they've got noise in them, essentially internal densities, one can't be as certain that they're not potentially just a cystic tumor, a cystic cancer. And because of that, these patients often get sent for follow-up ultrasounds, follow-up CAT scans, follow-up MRIs, and it just generates more business, more volume. And another thing was, it can be nice to get a new machine, the newest version of a CAT scanner, the newest version, let's say, of an MRI machine. And typically what's unique about newer machines is they can obtain thinner images, a thinner slice of tissue portrayed on an image. They can also often have higher resolution, see smaller things. Well, what happens is if you get thinner sections on a CAT scan of the chest, you see more lung micronodules, okay? The thinner the sections, the more incidentalomas you're going to see. So what I'm saying is the trend towards buying new equipment, at first you say, I'm going to get this new piece of equipment so I can see more disease, more pathology. And you do see a little bit more pathology typically. But along with that pathology, you see more normal variants, more incidentalomas. And I'll just tell you that that's a huge part of radiology. You'll a lot of times see a doctor who's a specialist in some field and they'll be kind of cocky, like let's say a pulmonologist. And they'll think that they know chest CT better than a radiologist or something, a general radiologist. But the problem is they might know more precisely the description of the staging of lung cancer. But what they don't know is all the normal variants. So they look at the abdomen. There's going to be all kinds of things. There's something in the spleen. There's something in the liver. There's something in the stomach, something in the adrenal, something in the mesentery, the gastrohepatic ligament, etc. So they just don't know that at all. So that's why they can't read these films. Screening brings in lots of patients. So you can screen patients for tons of things. Mammography for, looking for breast cancer. Chest CT looking for lung cancer, aortas with ultrasound looking for abdominal aortic aneurysms, cardiac calcifications as indicators of coronary artery disease, carotid intimal medial thickening as indicators of carotid atherosclerosis, liver ultrasounds for hepatocellular carcinoma in alcoholics, in hepatitis B, hepatitis C patients, etc. And a lot of times on these studies, especially the CAT scan studies, more so than anything else, more so than MRI, more so than ultrasound, they'll find incidentalomas that require the patient to come back for more imaging. You know, the joke, of course, is it's, you know, what's the theme song of radiology? It's like Hotel California, in the sense that the person can check out, but they can never really leave because there's always going to be a follow-up, almost always. It's more common with body imaging than it is with neuroimaging. So body imaging is, again, CT, chest, abdomen, and pelvis. And when a doctor orders a CT CAP, they expect to have a couple incidentalomas. It's just expected. There's going to be a follow-up for some reason. Versus in neuro fields like, you know, imaging of the neck, the brain, the spinal cord, the spine, incidentalomas are a lot less common. They still sometimes happen, but they're a lot less common. And those doctors in those subspecialties, they don't expect the incidentalomas so much, and they get annoyed if there's too many of them. Okay, some other things. So what I'm trying to say about radiologists is the radiologist doesn't have to do anything. But even in neuro, there are some incidentalomas. Let's say the patient has hypogonadism, low testosterone levels for unexplained reasons. They can sometimes do an MRI looking for a pituitary tumor. And it's really rare to see anything significant in the pituitary in that context. But often the pituitary will have other incidental findings. The pituitary will have normal variant non-functional cysts. Maybe it does have an incidental microadenoma. More commonly, you get a volume averaging artifact whereby the slice catches part of the pituitary and part of the adjacent bone, and it creates this fake artifact impression of a tumor or something, possible microadenoma, possible cyst or something. So that requires a follow-up imaging. So again, even in neuro, we see things that we need to do these incidentaloma follow-ups. Okay, so that's one of the real big risks of imaging. Patients aren't really aware of it, but a radiologist, I wouldn't want to put myself on a CAT scan or an MRI table unless I absolutely had to, because I wouldn't want to get stuck with all these incidentaloma follow-ups. But what I'm saying is it's a perfect business model. You don't even have to do anything. It doesn't matter who the radiologist is. There's just, you get a CT, chest, abdomen, and pelvis on anybody, there's probably going to be at least one incidentaloma. It's just automatically guaranteed to grow itself, the business. It's the perfect business model. Even if all the employees tried to stop it from happening, it still would happen automatically. And there's also the issue of CYA. That means cover your ass. And what that means in radiology is if I had a finding on myself that had a 1 out of a chance risk of a cancer, I would probably say screw it. I would let it go. I wouldn't even follow it up. I'd say those are good odds. I can live with that. But it's not like that with regular patients, because imagine you're a radiologist. You are going to see thousands and thousands of lung micronodules. So if you let them go every time there was a 1 in 100 chance, you would miss a bunch of cancers every year. So you can't do that. You have to follow it up. Now, some people say, well, artificial intelligence is going to replace radiology. No, I don't think so. And the reason is, like I just said, there's too many normal variants and, you know, sort of border zone, gray zone, fuzzy calls. When I first came out of residency, I was a real smart guy, perfect score on my boards. The old-time docs would often ask me how to phrase descriptions of pathology. What stage is this tumor? How would you describe this finding? And so I was a little cocky at first. I'm thinking, gosh, I know more than the old guys. But then what I soon realized was I needed to ask the old guys for help a lot more than they needed to ask me for help. And the reason I was always asking the old guys for help was, is this abnormal or is this a normal variant? There's tons and tons of normal variation, and you can only learn it when you've seen many thousands of these scans. So you just get a sense of what's normal, what's not. So I ended up going to the old guys a lot for help on, is this a disease or is this just normal variation, over and over again. Okay, so that's valuable. And what I'm getting at is I don't think artificial intelligence is going to replace radiology, because there's so much fuzzy stuff. There's so many artifacts that I think it's going to be hard to train an artificial intelligence machine to recognize that. Also, what I saw with EKG of the heart, you know, electrocardiograms, was that they wanted to keep a doctor's name on there so they'd have somebody to sue. So, you know, I think the lawyers insisted on that. What I also see happening is doctors, with all these progressively, constantly increasing volumes, doctors are super busy. There's tons and tons of work to do. And patients are incredibly stupid. By that I mean, Patients love going to hospitals. And you will say, oh, no, they don't. Oh, bullshit. Every hospital I've ever worked with in my life, every hospital I've ever seen in the Western world, there's always a giant line of patients every day that are going in for their CAT scan, their ultrasound, their MRI, their colonoscopy, their laboratory tests, and their surgeries, and all this other stuff, their checkups, their screening tests. What I'm saying is, for every person who goes low-fat vegan, something that will actually cure them of many diseases, there's at least like 20,000 that go for all these tests, and quite often they're not needed. Don't get me wrong. Once you start testing something, you're going to find something, and then they're going to feel obligated to go for the follow-up for their incidentaloma. So, but it'd be great to own an imaging center. It would be great to own these CAT scanners because they don't stop cranking out the volume. It happens automatically that the business grows and grows. But as a doctor, doctors get tired because they got to read all these films. And the films just get more and more in volume, more and more in the number of pictures. What I mean by that, for example, too, is the thinner the slices of an image, the more films there's going to be. For example, if you did an MRI years ago, let's say 15 years ago, you might have a couple hundred images to look at. Whereas you do, let's say, a brain MRI nowadays. A brain MRI nowadays pretty routinely is 1,200 pictures. So you really got to go through them fast in order to get them done in a timely fashion. So the doctors are super busy reading the bazillion films, and they're overworked. The lesson learned is I'd rather own a machine than have to read all these films. But, it's better to, have something to do. So anyways, I thought that was interesting how a radiology department automatically grows itself. I would invest in a radiology department if I knew how to invest in one other than just work in one.